I'm Ruth Hoffman. I'm the director of the American Childhood Cancer Organization, and very happy to be here with Vicki and CAC2 and Ginny, and members of CAC2 and members of ACCO, to welcome you to this primer on cancer action plans and childhood cancer action plans within our states. A little bit of background about ACCO. We've been around for 51 years. And we actually we're primarily focused on federal advocacy and legislation. From our early days, we actually were founded as a 501c4 by a wonderful woman whose name was Grace Monaco. And then over the last 10 years, and 5 years specifically, we started working on the state level advocacy, seeing that there was a real need to impact childhood cancer at the state level. So Vicki, if you want to welcome as well, that would be great.
Well, thank you, Ruth. It has been a joy and a pleasure to work with the team at ACCO, Ruth and Aubrey and Jamie on this initiative. I know that a lot of us have noticed that state advocacy is growing in importance because we'd like to be in DC, but we hadn't been able to be there this year. So travel to our state areas is oftentimes a little bit easier. And we were certainly proud to partner in this with Ruth and ACCO. Thanks, Ruth.
Yeah. The next slide. So we at ACCO did a landscape analysis about 10 years ago, and then repeated it in late 2018, early 2019. And at that point in time, we realized again that state level advocacy and state level funding was very lax, and specifically state cancer plans. 29 states had no mention of childhood cancer in their state cancer action plans. And if you don't have, any sort of focus on children within the state cancer plans, how are you going to get anything done? So that became a real focus of ACCO 5 years ago, when we hired Jamie Bloyd, actually, as a full-time staff person. And then in the last year, we also hired Aubrey. Both of you are well known in the community. So we have 2 full-time staff that are working specifically on making changes within the state cancer plans to make sure that there's data there. There's data specifically on childhood cancer, but also objectives and goals, and that children are part of state cancer plans. So that's really what our focus has been, and that's what this is about tonight. Over to Vicki.
Thanks, Ruth, very much for that historical perspective and the view of state cancer action plan landscape. Because of the work that makes this so important, ACCO and CAC2 are both working on state level initiatives, sometimes together, like co-hosting the primer for the state cancer action plans training meeting tonight, and sometimes in complementary ways, like supporting advocates getting license plates or awareness proclamations. And so we do have initiatives that we've got going at the state level that are mission and values aligned at CAC2, oftentimes building toolkits and connecting CAC2 members from the same state to help them advocate for changes in their state cancer action plans. You guys are here, you know that advocacy takes everyone doing their part, and ACCO and CAC2 have different strengths and different relevant networks, and working shoulder to shoulder together helps us accomplish more. We've designed the meeting tonight to help advocates learn about state cancer action plan advocacy through different lenses. One thing we've learned is that each state is a little different, and while we can't follow a specific recipe to make progress by watching and imitating one particular state or one particular issue area, we can learn generally what's possible and how we might customize our approaches to make progress for children and teens with cancer. A lot of that has to do with having good evidence, good data about the states, and taking that story forward. This evening, we're featuring 3 different case studies presented by 4 esteemed speakers. Dr. Eric Durbin will begin our series of presentations by familiarizing us with state cancer action plans and elucidating the example of Kentucky. He'll also offer the perspective of approaching this process from a healthcare professional angle. Our second presentation will be offered jointly by Joan Slaughter and Christy Cahill, who will show us an example of state cancer action plans and the impact of parent advocates and how they can have input into this process over several cycles of updating the plan in Colorado. Finally, rather than highlighting a third sample state experience, we'll turn to Peter Brown, who will present about his experiences working in Virginia and in other states to secure language around psychosocial concerns unique to childhood cancer. Next slide, please.
Yeah, Vicki, I think you did a great job of informing what Dr. Durbin's going to talk about. I'm so thankful for his expertise as the director of the Kentucky Cancer Registry. I'll turn it over to you, Dr. Durbin. Thank you so much.
Hi, good evening, everybody. It's my pleasure to join you this afternoon. So let's see. I'm going to try to get my screen shared here. So hopefully you guys can see. Okay, can you guys see my first slide?
Yep.
All right, excellent. All right, great. So thanks again for the opportunity to share my experience and my perspective with the group tonight. I'm the director of the Kentucky Cancer Registry, and in that role, I've been responsible for compiling data for all cancer patients, but we've focused recently on childhood cancer in Kentucky. But I'm going to share my perspective and how we've leveraged our population-based data to help facilitate both our cancer action plan and other childhood cancer-focused activities in the state of Kentucky. So I thought I would start with just some of the sobering statistics, and many folks on the call are probably already familiar with these numbers. Now, when I talk about childhood cancer, I'm talking about kids who are diagnosed between the ages of 0 and 19. But this year alone, in 2021, we're looking at over 15,500 new invasive childhood cases this year. Calculated a rough estimate, and we may be seeing up to 286 invasive cases in the state of Kentucky. Over 1,700 children are expected to die in 2021 from cancer, and up to 25 children may lose their battle in Kentucky this year. It's the second leading cause of death among children, only after we consider accidents. And folks are probably well aware the leading types of cancer, those being leukemia, brain and central nervous system tumors, and lymphomas. So I thought maybe it would be helpful to maybe set the context of state cancer action plans, and to help folks think through strategies for improving them to include references and plans to address the burden of childhood cancer. And so historically, the purpose of state cancer action plans is to really think about just reducing the cancer burden in a state population. And so when we think about burden, we're really thinking in terms of the morbidity or the incidence, the new cases of cancer, trying to prevent those, and the mortality and death from cancer. So the audience that the plans are directed towards in general are for cancer prevention and control professionals and other stakeholders. And these plans can also be used as an important document to prioritize resource allocations by the state legislators and sometimes at the federal level as well. But historically, these plans have been more focused on adult cancers, and they're typically thinking about and thinking through the challenges of developing screening and prevention programs, primarily focused on adults. So when we think about screening for cancer in adults, it's screening for breast cancer, colorectal cancer, prostate, cervical cancer, and more recently lung cancer. And then when we think about prevention, it's prevention in terms of reducing the risk. So reducing smoking, obesity, maybe HPV infections, and getting folks vaccinated and that sort of thing. But again, these efforts traditionally have been primarily focused on adult cancers, and I think incorporating childhood cancer can be somewhat challenging. But I thought I might also share with you at least the model that we've employed in the state of Kentucky. Thinking about how we go about conducting, cancer prevention and control activities. And I think this is a reasonable model that other states are employing as well. And it gives us a good framework, I think, to think through maybe the challenges or the strategy that we may want to consider when incorporating children into our state cancer plan. So importantly, it's important to base our decision making on data. And so it's essential that we actually measure the burden and identify the issues. In this case, it may be the incidence of cancer in the childhood population. And so we rely on our cancer registries to provide this information. And I'm going to talk quite a bit about the data that we've compiled to help move these efforts along in the state of Kentucky. So once we've measured the burden in the population within our catchment area, and typically at the state level, it's important then to identify where the burden is highest and to select the target populations that maybe are appropriate for interventions. And then we use that then to develop an intervention strategy, and then we act by implementing a plan. And it's important to be able to measure whether or not the plan that we've implemented has actually had an effect. And so we can also use the registry data in the case of cancer incidence or maybe the stage of diagnosis to measure whether or not our screening program or other activities have actually had a measurable impact. And it's a continuous cycle, and we collaborate, of course, with folks in the community and healthcare providers and others, and it's a continuous cycle. And as we improve in one area, we identify additional areas where we need to continue our work. Now, I do think there are some challenges when thinking about prevention of childhood cancer, and I mean the truth is our knowledge of the risk factors that cause childhood cancer is really still pretty limited. We do know there are a number of genetic risk factors that can be inherited. We know that medical radiation, which is actually a treatment for cancer, can cause the tumors later in life. Chemotherapy as well. There are a limited number of infections that are associated with cancer and exposure to certain chemicals. But for the most part, it's really hard to think about how do we prevent cancer in kids, and I think that maybe is one of the reasons why it's been challenging for folks to think about incorporating childhood cancer into their action plans. It's clear to me that we need additional data, and eventually we may get to the point where we actually can strategize about actually preventing cancer in our children. But on the other hand, I think it's appropriate to focus then on survivorship and survivors. So thinking about the ways to optimize, treatment for childhood cancer, ensuring, for example, that kids maybe are seen in the most appropriate facilities, which maybe in most cases are probably the Children's Oncology Group facilities. Thinking about making sure that where appropriate, children have access to clinical trials that may be addressing a rare or challenging tumor. It's always, I think, beneficial to increase awareness of childhood cancer. And in fact, when I share the data that we've compiled in Kentucky, I've learned so much that I just didn't realize, and I think that's probably the case in other states. Also, I think it's important to strategically think about increasing survivorship, healthcare resources. A number of kids, as a result of their initial, cancer treatment, they may be facing subsequent tumors, later in life. So ensuring that kids are appropriately screened for subsequent cancers is likely important as well. Increasing support for research. I think you guys, more than anyone, are aware that the dollars invested in childhood cancer research are minuscule compared to the dollars invested in adult cancer. So thinking about increasing our research resources to identify causes, improve treatment, and eventually, hopefully, also engage in actual prevention of childhood cancer. So I thought I would also just kind of walk through the steps that we've employed, at least in Kentucky. This is just one example, sort of employing the framework that I've described. So again, we want to start by measuring the burden in the population. And I think it's important to look at the burden within the state and also to compare the burden in your state with other states or kids in other states experiencing more cancers of certain types or fewer. To sort of assess, where your particular population, falls in comparison to others. Again, selecting a target population to develop an intervention strategy. We might want to look across our population and identify certain cancers that may be higher in your population or your state than in others, and do children in certain areas within your state experience higher rates than others, and if so, that may be an area where it would be beneficial to develop an intervention plan. So once we have a plan in place, then implementing that can proceed. And just in our case, and I'll actually walk through an example with you today. It was important for us to actually collect additional data. We didn't have enough data to answer some of the questions that we had in the context of our intervention plan. And eventually, advocating, using our findings or the intervention plan itself may involve advocating for policies or resources ultimately to reduce the burden. And then again, at the end of the day, has our intervention actually had an impact? So have we reduced the burden in a measurable way? Have we increased knowledge? Have we increased resources? And so forth, and so on. So at this point, I'm going to talk about measuring the cancer burden in a population to support evidence-based decision making. So the question is, how do we actually know the burden of cancer in the U.S. and in Kentucky? Well, it's through our population-based cancer surveillance programs or our cancer registries. Every state has its own population-based cancer registry, and these registries are mandated by state laws. While we get support from federal agencies such as the National Cancer Institute and the Centers for Disease Control and Prevention, the mandate that permits a registry to collect data, including identifiable information, comes from the state legislatures. Kentucky, we have a state law that established our registry in 1990, and it stipulates that all facilities that diagnose or treat cancers must report data to our registries. And all states today have registries in place, and most registries are actually really quite good. And from the beginning, I would say that our registry and others, we've always collected childhood cancers, and so it didn't require, hasn't required new initiatives to collect those. So just a brief history of our registry. We actually began as a volunteer organization in 1986. Formally established again by state law in 1990, implemented in 1991. We became part of CDC's National Program of Cancer Registries in 94, receiving additional funding from them so that we could collect data from non-hospital facilities. We became part of the NCI SEER program in 2000. And then, fortunately for me, we started participating in CDC's Pediatric and Young Adult Early Case Capture program in 2012. And this was really the program that directed my attention to childhood cancers and helped us develop our focus there, which I believe has been consequential. However, it took us a while to actually compile childhood cancer in a way that was consumable or available to the public and the policymakers and legislators in the state of Kentucky. So regrettably, it took us 30 years from the time we started before we actually had published data specifically focused on childhood cancer. So it's not so, and I think it's still relatively rare. So I'm not actually aware of other cancer registries who have produced these reports, but it has proven very beneficial to our advocates and others who are just grateful to have this information. So I hope our example maybe leads to other cancer registries taking taking this on to produce more detailed information for folks to utilize, and particularly to utilize in their cancer action plan. So I thought you might be interested in taking a look at the data that we've compiled for the state of Kentucky, perhaps as a model that others could consider. But first, I wanted to share with you that there are some challenges that we have in thinking about compiling and making data available about childhood cancers. I think you guys are well aware of the fact that these cancers are relatively rare in relative terms. So less than 1% of all cancers diagnosed in a population are actually childhood cancers. So the rarity and the small numbers actually make it somewhat difficult to make meaningful statistical comparisons. And for example, the best way to compare the cancer burden is to actually compare age-adjusted rates, and I'll talk about that a little more in just a moment. But when we're looking at rare events or small numbers of cases, the rates that we calculate tend to be unstable with small numbers, and as a result of that, it's really hard to make comparisons that demonstrate statistical significance, so that we can say, well, this area has a significantly higher rate than another area. Another thing we have to keep in mind is that rare events potentially increase the risk of breaching patient confidentiality. And so, for example, it might be easy to identify a child who's diagnosed with a rare tumor in a small geographical area. So it's important that we don't publish data that indicates small numbers in a way that someone might be able to identify a particular individual. So we always have to keep patient confidentiality in mind. But there is a solution to this, and I think it actually works reasonably well. We either expand the geography for the rates that we're calculating, or we expand the time period. We found in Kentucky that there are only just a few counties where we can actually calculate childhood cancer rates that are unstable. So even the county level data is probably too small, but we found a way to combine counties into what we refer to as area development districts that make those comparisons possible. And then we summarize data across multiple years. So we found in general that 10 years of data is sufficient to get to the point where the rates are stable enough that we can present those in a public forum. So I'm going to share with you just some of the data in tables and graphics that we've curated to describe the burden of cancer in our population. This graphic indicates that childhood cancer occurs more frequently in males than females. That was actually, I didn't realize this until we actually compiled this report. This is a graphic comparing males in blue and females in pink or red here, just looking at the raw numbers. So we're not looking at rates here, we're looking at the actual burden, the number of kids that were diagnosed in this 10-year period from 2009 to 2018 in Kentucky. And I was also surprised to learn, and many of you may already realize this, that childhood cancer occurs more frequently in younger children than it does in children, ages 5 to 9 and 10 to 14. And then it picks up again for children between the ages of 15 and 19. And then if we extended the graphic out, those numbers would increase over time through adulthood and into the older population. But an interesting finding here. So we're presenting a comparison here so that we can see by the type of cancer, which types by numbers are occurring more frequently in males and females by cancer site. It's some differences. In general, the numbers are greater in males than in females. It's a little surprising. It sort of stands out that the epithelial tumors and melanomas occur much more frequently in females than in males, and that's probably related to younger women who are using tanning beds, resulting in increased incidence of melanomas. But interesting just to look at the comparison here by sites and by gender. An important graphic, just understanding the most frequently occurring types of cancer are leukemias, brain and central nervous system tumors, lymphomas, and then again, these epithelial tumors, including melanomas, and germ cell tumors, make up about 78% of all cancers diagnosed in Kentucky, and there will be similar proportions diagnosed in other cases. So this is our first presentation of actual rates of cancer, and again, these are our most important resource for actually making comparisons between populations. And one thing I'll point out here is that in general, in childhood cancer, when we calculate the incidence rates, we're calculating the rates, presenting those as the number of cases per million individuals who are at risk for being diagnosed with that cancer. Now, this is different than what you're likely to see if you're looking at descriptions of rates in adult or all patients of all ages. And it's important to keep this in mind. So we wouldn't want to compare the rates of childhood cancer with adult rates because they're using a different denominator. And I think one reason we do this is that, again, it's related to the relatively small numbers of cases. The rates are relatively small, and so it might be kind of strange to look at a rate that was, for example, when we look at the hepatic tumors, of 0.4 per 100,000. That's a little hard to get your head around. So I think it's easier to understand the numbers and the rate when we look at it or calculate it per million patients who could be diagnosed with that type of cancer. Now, this is a troubling graphic that's looking at the incidence rate for both males and females, over time. And what we observed in Kentucky and what we're reporting here is that the rate is actually going up annually. And I'm showing the actual trend graph here for 2009 to 2018. But for comparison, I've also presented our historical data from historical reports that also calculated the increase. So it's in Kentucky from 2007 to 2016, the rate was increasing at approximately 1.8% annually, and 2.5% in the next 10-year time period. We move forward again, and around 2%. But it indicates, while the exact proportion of change, may vary a little bit, it's clear that the rates are actually increasing, which is not the trend that we really would hope to see in this population. But this is the case in Kentucky, and it's true nationally as well. So here we're actually making comparisons now finally within Kentucky and looking at the rates in groups of counties called area development districts. And in addition, we plotted here the red bar that you see in the graphic here indicates the statewide rate, and we can compare the rates in each ad district to the state rate. And we're also including the 95% confidence intervals. Now, confidence interval basically means that we have 95% confidence that the actual rate falls somewhere between the upper bound and the lower bound. And this gives us a more reasonable way to compare areas where the confidence intervals may differ. And we see from this graphic that that confidence interval does not overlap the state rate. So we could say that there are not significantly higher rates in any of the ad districts compared to the state rate, just looking at making a comparison within the state of Kentucky. However, it appears to me, and probably appears to you as well, that the rates are higher. The highest rates are occurring in our eastern Appalachian region of the state. And so this is actually a highly burdened population of patients within the state of Kentucky, within our Appalachian region. We actually experience, looking at cancers of all ages, the highest rates and the highest death rates from cancer anywhere else in the U.S. And so for us, for our particular population, it's important to be able to make these comparisons as well. So here we're comparing the rate of cancer in children in the Appalachian region compared to the non-Appalachian region that's depicted here in yellow. Now, again, in this case, these confidence intervals do not overlap, so we could say, well, the rates are higher in Appalachia, but not significantly so when we're looking at all kids who were diagnosed within this time period from 2009 to 2018. So this is how we've described the burden of cancer in Kentucky, and I'm gonna move on to show how we've used these data and other data that are actually available to everyone on the call today, publicly available, to make some additional comparisons to maybe focus on the burden that may exist within your state as well. So in this graphic, we are using data that's publicly available on CDC's website. These are national data that are contributed by the NCI SEER program, as well as the CDC National Program of Cancer Registries. And all that data has been compiled and made available on a public website. And so you can use the URL that's in the slide here if you wish to go look up the CDC Wonder website, and they have a way to select childhood cancers and to make some comparisons for yourself. And so here we're comparing the U.S. rates that are available on this website to the Kentucky rate, and then we've used data from the Kentucky Cancer Registry to also make a comparison with our Appalachian region of the state. And what we see here is that for 11 of the most frequently occurring types of cancer among children, in 7 out of 11 of those, Kentucky kids, either statewide or in the Appalachian region, experience a higher rate than all kids in comparison in the U.S., which is somewhat troubling. As far as significantly higher rates, we've identified in this particular time period that the rates of leukemia, the brain and central nervous system tumors, as well as the epithelial tumors, including melanomas, are higher in our childhood population compared to all kids in the U.S. And so that's a troubling trend for us. But in particular, it's the brain and central nervous system tumors that have really stood out for us. And as we look carefully at those, and we've looked at those rates over a number of years, the rates in Kentucky have always appeared to be higher. And I think this is a really nice graphic to just sort of to see where we rank compared to all other states. And that's exactly what I've done here. And again, these data are completely available to you that you could download and incorporate this into an Excel spreadsheet and generate this graph. That's what I did to generate this. And in this case, we're looking again at the brain and central nervous system tumors from 2008 to 2017. And in this particular time period, Kentucky ranks 3rd highest compared to all states. And we usually rank somewhere between 3rd or 4th or 5th, or somewhere certainly in the top 10, but we're not alone here. There are 11 states that appear to have significantly higher rates of brain and central nervous system tumors compared to the U.S. as a whole. And so this, at least, provides maybe some evidence that it may be worth looking into the issues in other populations. Now, I will say, there could be challenges with data. We have, I think, a very good surveillance program in Kentucky. So I think our registry and our contributors around the state are very good at identifying and submitting cases to us. And some types of cancer may be underreported in other cases, which may impact where the ranking may fall. So the ranking itself is not so important, but it does maybe give you a sense for where your state compares to others. So I'm going to conclude now with a real world example from our state and how we've developed and implemented an intervention strategy to address this high burden of brain and central nervous system tumors that we've identified in our population. So we were very fortunate, and through the hard work of advocates such as Jamie Floyd and others who paid close attention to the data that I just shared, they were able to advocate for state funding to support some research focused on the problems that we have related to childhood cancer in Kentucky. And so myself and a team of investigators at the Markey Cancer Center were fortunate to get to receive funding to help us explore further this burden in Kentucky. So there were 3 aims to our study. First, the question always we think about, with higher rates as well, was there an environmental exposure? And so the first objective of our study is to look at potential exposures that maybe would explain, why these rates are higher within Kentucky. Another very important aspect of the study is to actually try to better understand the genomic makeup of tumors that are occurring within our kids. And so the second aim of the study actually involved going out and obtaining historic residual tissues from biopsies and resections, and obtaining those tissues through the Kentucky Cancer Registry and collaborating with a partner at the Children's Hospital of Philadelphia who's providing genomic sequencing for these tumors in Kentucky. And then the third aim of our study is to ensure that the data that we're collecting and working so hard to gather can be shared with others so that other kids and other researchers can benefit from the data that we're collecting. And likewise, we're leveraging data that others have collected about these tumors to make comparisons with the kids in Kentucky. So data sharing is just critical, and it's clear to me and others that we may find additional answers in treatment and maybe even prevention eventually through sharing of data. And of course, one aspect of sharing of data is that we continue to protect patient confidentiality, which is always a central priority for us. So I'm going to share with you just some of the results that are coming out of the study. It's still ongoing. Of course, the pandemic delayed progress on the study, but we are moving along now quite well. So the first thing that we've identified and published about is looking at the rates of these brain tumors within the state of Kentucky. We've actually identified this cluster of counties where children living in this area from 1995 to 2017 experienced an increased risk compared to other kids within the state of Kentucky for being diagnosed with the brain or central nervous system tumor. And so the risk for these kids during this time period was an almost 50% increased risk, which is a very interesting and of course, a troubling finding. We were a little surprised to learn that the risk was not just isolated to Appalachia, and so the risk was also higher for children living in the central and north central parts of Kentucky, which is leading us to pursue some other avenues of research and collecting additional data to try to explain that. I'm not going to, this is a very complicated slide, and I apologize about that, but basically we implemented in collaboration with the Kentucky Cancer Registry in their virtual tissue repository a rather sophisticated process for obtaining tissues and then providing those to CHOP for sequencing, and doing all that while protecting patient confidentiality through honest brokers and secure mechanisms. But this has actually worked extremely well for us. Our goal was to obtain 250 specimens, and we actually ended up collecting 258. And so CHOP is in the process of continuing to sequence these tissues, and the data is already proving to be intriguing and thought-provoking in producing additional hypotheses. So this is just an example of some of the sequencing results that are now emerging from this data set. We were surprised, early on to learn that the KMT2C mutation was prevalent in the set of specimens that we had sent to CHOP. So it'll be really interesting to see how this pans out as we get all those specimens sequenced. We conducted some comparisons that are showing some genomic profile differences, comparing our pilocytic astrocytomas with the non-pilocytic astrocytomas, and looking at some obvious differences here that our biostatisticians have been able to demonstrate for us. And so we're really, again, looking forward to getting all the data sequenced for analyses. And eventually, we will be combining both the genomic results and the environmental data that we've collected. Now, there's a second phase of our study is underway, and importantly, one thing we didn't have in the initial study was germline specimens to be able to make comparisons with inherited genes for the population. So in the second phase of our study, we're actually contacting the survivors and requesting them to complete a household survey and to also provide a saliva sample so that we can incorporate that into our analyses. And I'm really pleased to report that we've gotten a really positive response rate from these kids, these survivors, and their families. It's really been quite remarkable. The surveys are underway. We're collecting much more extensive data about potential exposures that these kids and their families may have been subjected to that may be associated with increased risk for these tumors. And again, we are also sharing these data with our collaborators with the Children's Brain Tumor Network, and we're also now engaged with the National Childhood Cancer Registry that's being led by the National Cancer Institute. So This has continued to be and continues to be, we think, a very important study, and hopefully will be impactful at the end of the day. We hope to be able to measure the impact of the study and the effect in reducing the burden, hopefully, for kids in the state of Kentucky. And so that's really everything I have to share with you today. I appreciate your attention, and I think we're going to hold for questions until later in the meeting today. So thank you.
Thank you so much, Dr. Durbin. You're amazing. I'm going to queue up our next set of speakers, and Ginny's going to introduce our next set.
I am so pleased to introduce this powerhouse team of ladies from Colorado. Joan Slaughter and Christy Cahill have been involved with childhood cancer advocacy for nearly 20 years. Along with her late husband, Joan founded the Morgan Adams Foundation and is now the executive director of the organization named after her daughter. In addition, Joan serves as the chair of the Colorado Kids Cancer Association, an organization that brings foundations from across the state together in efforts to impact childhood cancer. She's also a founding member of CAC2. Joan worked on one of the very first state cancer action plans that included childhood cancer, and tonight she shares her experience and vision for state cancer action plans. Christy has dedicated her professional career to work with cancer nonprofits. She is currently the executive director of the Colorado Cancer Coalition. She facilitates leading effective coalition echoes and managing effective coalition community of practice. Basically, she gets people to work together to get things done. These ladies from the Mile High State have most definitely gone the extra mile for childhood cancer advocacy, and I can't wait to hear what they have to say. Ladies?
Hi, thank you so much for having us tonight. We really appreciate being here with you guys. I am going to share my screen, and then Christy and I will get going for you. So, all right, we are here to tell you a little bit, I think a little bit differently about our experiences in working on actually authoring a state cancer plan. Okay, so joining in with the national conversations and looking at how cancer and the continuum of care was being presented across the country. Here in Colorado, we joined with the CDC's efforts to start drafting cancer plans at the state level. So in 1996, our first plan was published, and that was as part of the Cancer Prevention and Control Plan. We went forward in 2000 and with the idea that we would be able to implement 10-year plans. In 2004, Christy will talk a little bit about Amendment 35, which was the tobacco legislation that was passed here in the state of Colorado. And at that point, we took a look at our 10-year plan and decided that we needed to move into 5-year iterations. And so the 2000 plan was originally intended to be 10 years. And then we did a revamp in 2005, and that was published in direct response to Amendment 35. From that point forward, the plan started having 5-year iterations, and we'll walk you a little bit through the progression of how those plans evolved and where we are as things stand at the moment. So, Christy?
Yeah, so in 2010 is when we did the first. Did you want me to go to the next slide or this one, Joan? Okay. 2010, Joan was a big part of creating the first pediatric chapter, and that was the 2010 to 2015 version. Even within the pediatric chapter, we had lots of different pediatric voices at the table for that version. Much thanks to Joan for bringing doctors, other physician champions, and supporters to the table. And then in 2015 to 2020, we reframed it to go along the continuum of care, and the pediatric chapter actually went away, and it was infused all throughout. I'll say all throughout. It was infused a little bit throughout the plan. And then now in 2021, we are trying to, again, make sure that the pediatric and AYA has a much stronger voice in this next plan that will go out. So we'll go into that all in a little bit more detail. So she mentioned the tobacco tax. So in 2004, we voted to increase taxes, which actually put us on par with having some of the higher tax rates on tobacco. But as we hit 2007, other states started to go further and add more taxes, and now we're back in the bottom in terms of tobacco tax. But what the tobacco tax did do was add a lot of funding in cancer prevention, some in cancer screening, and then some in cancer support. And so I'm going to dive just a little bit in to show you where this money goes. So the tobacco taxes, when it comes in, it gets split across these 5 different buckets. And so cancer is seen here in the 16% bucket and here in this 16% bucket. And I'm going to talk mostly about this bucket here that then breaks down even further into the Health Disparities Grant Program, the breast and cervical cancer expansion, and the grant program, and then this competitive grants program. So out of the 16%, a big chunk of it goes to breast and cervical cancer screening and getting people in the door to get mammograms and pap smears. And then the other place where you see money going is into the cancer, cardiovascular, and pulmonary disease grants program. But the caveat there is that only 10% of this has to go to cancer. So right now it's going towards 2 HPV grantees, a radon grantee, and a colorectal cancer screening grantee. And then the rest go to cardiovascular, pulmonary, and other diseases. So a lot of the tobacco tax goes for health-related grants, but not all of it goes to cancer. There's also a big chunk then that goes towards the tobacco side of things. So that's one way that Colorado helps fund the cancer plan. And then I just wanted to go into a little bit more detail for other ways that we fund the cancer plan. As you can see though, you know, what I'm about to talk about adds up to maybe about $75,000 a year, which is a teeny chunk of being able to actually implement your cancer plan. Annually, we get about 18 to 20,000 from the state health department for cancer plan implementation. We actually, in Colorado, we have something called the Colorado Cancer Fund, which is when people file their state taxes, there's a list of nonprofits they can donate to. If they get a refund, they can donate their refund back, and then it goes to the nonprofit. So the Colorado Cancer Coalition benefits from those donations, and then we put together an advisory board who looks at grant proposals and then fund that back out into the community for cancer plan implementation. And then we also get miscellaneous donations from organizations and corporations to help fund the cancer plan. But you know, 75,000, again, not enough to implement an entire cancer plan or even really, you know, one objective really well. So a lot of how we get our work done is through all the partners coming to the table and leveraging each other's resources and collaborating, figuring out who has resources that can go towards marketing, who has resources that can go towards lobbying, you know, just figuring out what each partner brings and how you can capitalize on it. Back to you, Joan.
So, well, we talk a little bit about how the plan gets funded and how it developed. The next part of what we wanted to kind of share with you is a little bit about how we actually started to weave pediatrics into the Colorado State Cancer Plan. So Christy talked a little bit about having the various groups that would come together and work on how can we leverage each other's resources in a way that pushes forward our collective mission. So the little kind of ball in the middle diagram up in the upper left-hand corner is the kind of the roadmap for the original Colorado Coalition, the Colorado Cancer Coalition, which basically had been broken down into various task forces, and the task forces were aligned with particular cancer types. Independently of the CCC, in 2006, a group of nonprofits here in Colorado got together and decided that we had some similar issues unbeknownst to us, that we were having parallel conversations about how could we come together and pool resources and really look at how could we be more effective and serve our broader Colorado cancer family community more efficiently. So we formed the Colorado Kids Cancer Association, and the kind of org chart that's underneath the CCC diagram is really the inherent structure of what we were, the ambitious inherent structure of what we wanted for CKCA. And then as we met and learned more about the Cancer Coalition itself as the adult group, they asked us to join them as the pediatric task force. And so we wove into our member obligations representation at the larger coalition meetings. And we really looked at each of the task forces to determine where pediatrics had implication. And we asked each one of the CKCA members to also join an adult task force so that pediatrics would be represented in the conversations that were happening at the adult level. So I think we can go to next slide. So as part of our work as the pediatric task force, that is then also when we were invited to really take a hard look at the cancer plan and weave pediatrics into it in the best way possible. For the year that we were working on, so we started drafting in 2008 for the 2010 plan. And at that time, the Colorado State Cancer Plan was aligned with the task forces, and each individual cancer type had its own chapter in the plan. And so we were able to author a fully independent pediatric chapter. And one of, it was a very exciting time for us. It was a lot of work, but one of the things that we really focused on was identifying the unique needs. And I think Dr. Durbin talked a lot about some of the things that are implicit or understood in adult cancers don't always apply. I think we all know that to peds. And so this was an opportunity for us to really articulate the very unique and special needs of the pediatric AYA population. So, we were able to put in 9 specific pediatric goals. And as we were authoring this, I think a focus on resources and execution was really something that we tried to bear in mind. What could a group of independent nonprofits do to actually affect and implement some of these particularly lofty goals? We did have buy-in from frontline clinical practitioners. But one of the things that we found, even in Colorado, at the time we had only one children's hospital center of excellence that was serving basically a 9-state region, but getting the institutional level full leadership buy-in into this process took us a little bit longer than I would have anticipated, to be totally honest with you. But ultimately we were able to get it done, and it was published. And this particular chapter was ratified at the Congress, at the Cancer Action Plan Congress by all of the states, tribes, and territories that were present at that particular meeting. So then next slide. Thank you.
All right. So I'm going to talk then about what happened to the pediatric chapter and how it's going to come back. So in right around 2013, 2014, the coalition started undergoing some restructuring, and there were then changes at the coalition level, the CKCA level. Both, like, I was having twins, Joan was having to step away as well, and CDPHE had turnover. There was turnover everywhere, and so the state health department still had it in their comprehensive cancer unit's goals that they had to create a cancer plan. And so they really took on the entire writing of the 2016 to 2020 cancer plan, and looking at the national landscape, reviewing what some other states had done with their cancer plans, they decided to go on the continuum of care model. So going from prevention all the way through treatment, survivorship, end of life, and then at the very end added a cross-cutting section that crosses the whole continuum as well. And so they took away the body part specific chapters and took away the pediatric chapter and infused it throughout. There are only 11 mentions of pediatric AYA anywhere in that document. So it's not nearly as highlighted as it used to be. And that's, I mean, I would attribute that mostly to there was a much smaller voice in the pediatric community at the time when that one was written. And now we've got a stronger voice back at the table. So I won't jump too far into that, but this just really reiterates, like, be at the table, have a strong voice, have champions behind you to get that buy-in and show the credibility for the voice that you do have, so that you can make sure that pediatric AYA considerations are included in your state cancer plan. Do you want to add anything to that, Joan?
Perfect.
So we are in process of writing our 21 to 2025 version. We had an advisory committee that reached out to subject matter experts all across the state, including our task forces. And so since CKCA is meeting again, we reached out to them, and we're in the process of including their feedback into this next iteration. We are going to continue into the continuum of care model. We really want to be able to track from the version we wrote in 2016. We really want to be able to track over time where we're moving the needle and where we need to do more work. So we are trying to publish one that will be very similar to the 2016 version, but with including more on the pediatric AYA specific issues and getting those put back in. And we definitely want to look at differentiating pediatric and AYA specific needs that are different than, the adult, than trying to prevent adult age onset cancer. So much to what Dr. Durbin was talking about, like trying to figure out what those causes are. And then also looking at other key areas of needs for the pediatric and AYA population, like quality of life and late survivorship and late effects, as well as fertility issues. So our next version will have more than 11 references to the pediatric AYA community, and just call it out more like it used to be in a previous iteration. Anything to add, Joan?
Yeah, I think it's important to note that the Colorado Department of Public Health and Environment is very involved in this process, and they are the data gathering entity for the state of Colorado. So we also have access to significant statistics and trend in disease rates, and all of that factors into a lot of this process that happens behind the scenes. There are whole sections of the plan that are dedicated to really ensuring that we're identifying great areas of need for our statewide population and addressing those in the plan. So our intention from the CKCA perspective is just to really ensure that we are also factoring in all of the PEDS AYA data into those collective kind of language pieces that roll up into the plan. So we thought we'd just share with you a little bit, and I think maybe this slide is a recap of some of the things that we've already talked about a little bit, but after now kind of working on 15 years of dealing with conceptualizing state cancer plans and how do we have grassroots advocates at the table and ensure that the voices are being heard. I think that what you'll see, the very biggest challenge that we have identified as we look back over the history of this and the changes that took place in 2016. I was on personal sabbatical, Christy was out. Leadership changes really indicate that there has to be a very strong cohort of advocate voices at the table. I think that's probably the single biggest takeaway that we have in order to ensure that the pediatric AYA population, the community needs are addressed and brought forward into the plan. I think the other thing that Christy and I have had a lot of conversations about is ensuring that you have partners at your state health department and in their cancer plan, their cancer program units, but really looking at how do you get legislative champions brought in. And I think the work of CAC2 and specifically, I know Vicky's been working on license plate kinds of things, all of those things that take significant state legislative activity is a really important part of the conversation when you're looking at how can you find your champion that's really going to help ensure that whatever you are authoring for your state is also actionable and that it has support in the legislature. Deliverability, I think, is the next thing that we really talk a lot about. So it can't just have community and grassroots leader buy-in. You need to have your clinical, scientific, and care provider buy-in as well. So representation from probably all of your institutional partners needs to be a real consideration when you're drafting these, but also your C-level executives. We found a lot of times, and I shared with Vicki, one of the big cases in point for us, we have a lot of rural communities in Colorado, and we have some hard to reach mountain communities. And so even back as far as 2008, we were talking about telemedicine. How do we implement telemedicine? We had a couple care providers for whom rural communities were a personal passion and a personal priority. And so we were able to weave it into the plan. But if the institutional leadership doesn't make telemedicine and telehealth a priority, it's almost inactionable and you can't execute it. So really having leadership buy-in is a significant part of the conversation. And of course, with everything that we do in the pediatric AYA community, funding is just a critical component of how you get things done. And just lastly, I think Christy would agree with me without hesitation that it's a lot of work. And so I think while our task force model has changed a little bit over the life cycle of this process, as many subspecialists as you can have at the table, as many grassroots advocates as you can bring forward that have a real commitment to not only the authoring, but really helping hold the community accountable for implementation, I think is a critical component of not just getting your state to adopt pediatric issues, but to really make sure that you are able to get fulfillment of the plan. So anything to add, Christy?
Nope. Okay, so we wanted to leave you with some final thoughts around where to start. So continue, conversations like this, continue to engage in and share national cancer conversations. And I would also really reiterate the local level too. So attend if it's a cancer consortium, cancer coalition, they're all called slightly different things in every state. But find out where your coalition is, because if your state, every state that has a comprehensive cancer grant, should have a coalition as well to help carry out the work and create the cancer plan and be that cancer voice in the state. So engage, set goals, look at that data, talk with the hospitals, talk with the social workers, talk with financial counselors, depending on where you're finding the needs, find who are those people that should be at the table to help prioritize. And actually, I will reiterate, prioritize. Every year, I think everybody there's so much to do, and it's, you just get kind of stuck because there's so much to do and it's overwhelming. So prioritize 1 to 2 things that you want to work on. Again, bring the right people to the table and then figure out who can help fund that. And then the third thing I'll mention is aligning with your state health department, figure out who the comprehensive cancer program manager is, figure out who the executive director is for the Cancer Coalition, and make sure you have a seat at the table. And then, you can start the conversation around how can pediatrics have a voice in the state cancer plan.
And then I think our last point is just really represent, right? I think for all of us and the people that are on the call are highly invested in this. Really representation is the best way to get this done, making sure that we're bringing forward new advocates to serve on the boards and that everyone has a voice at the table and that everyone is heard. I think that's probably the biggest the biggest next step. It's really growing our constituent here in Colorado, really getting everyone back to the table. So I think that's it. That's where we're at. We want to thank you all very much for having us. We appreciate being able to share our version of the journey. My apologies again for my glitch on the front end of it, but thank you very much. We appreciate it.
Yeah, thank you for having us.
Okay, can you guys hear me?
Thank you, Joan and Christy. Great job there. It's Aubrey, and I just want to introduce our next speaker. We have Peter Brown with us. He is SVP of Client Services and Operations at WellTalk, but he is also a board member of MedStar Research Institute, which is a Georgetown University joint oncology institution, and he's a part of that review board there. But last and absolutely not least, Peter Brown is the co-founder and CEO of Maddie Miracle Cancer Foundation, and we are honored to have him as our next speaker tonight. So thank you, Peter, for being with us.
Great, can everyone hear me?
Yes.
All right, good. I was gonna show my slides, Aubrey.
Yep, I'm going to stop sharing so you can do that.
Great, thank you. And I'll go to presentation mode, and Aubrey, you'll tell me that you can see it, right?
You are good, yes.
Okay, good. So I have the unenviable position. The sun has set here in Washington, D.C. It is now 8:09 p.m. So I'm going to be short and sweet. You guys have heard about two really strong efforts and programs, both in Kentucky and Colorado. So I'm not going to bother to touch any of that. They gave you a lot of great information, better information than I could give you. So I'm just going to distill down, because I know it's the end of the day for everybody here, what I think are the most important things from my own selfish perspective. You've heard about state health departments. You've heard about the fact that pediatrics are not well represented, and I don't want you to underestimate that impact. And I see so many familiar faces and names on the Zoom here. So hello, everyone. It's great to see you guys. But the thing I do want to promote, though, is that in addition to the fact that most state cancer control programs don't have a lot of peds representation, in addition to that, they also don't have a lot of psychosocial representation. So, which everyone who knows me knows that that's what we're all about. And so I just wanted to throw out to this group, if you don't know already, that there are evidence-based psychosocial standards of care, so that as you're talking to state cancer control programs, you're talking about, the importance of the medicine and the treatments, but you're also should be talking about the fact that there are evidence-based standards of care. And I want to specifically call out Jamie Bloyd. I want to call out Amy Godkin in Virginia. These two ladies have done a lot in their states, not just their individual states, but to help expand the message about childhood cancer, that it's not just about the medicine, that it's also has to be looking at the psychosocial components as well. Again, I don't have to go into a lot of that stuff. We do have a toolkit that's being pumped out. It was published actually last year during the COVID craziness. And so I think a lot of people missed it, but it's really designed for programs. So think about the 200 plus comprehensive cancer centers that treat children with cancer and their families, that there's actually now a toolkit out there that they can self-evaluate how they're doing against these standards of care. So again, that's another great input into the state cancer control programs. I called out a couple of states here. I think Colorado and Kentucky are probably the leaders in those, but New Jersey's been doing well. Virginia's been doing well. You can ask Amy Godkin of the Ask Foundation as well. She's been instrumental in working to get the language expanded as well. Every state needs this, as you guys know, as you've heard over the last hour plus as well. But I called out the New Jersey example, and these slides will be available to everybody. But it really tries to get to the importance of psychosocial. And then here, Amy's probably going to smile at this, even though I can't see her. This is just an example from a program filing in Virginia, and I've called out at the bottom there, section 3.2. but it's real basic stuff, but it's very important. It's educating providers about the importance of psychosocial. It's assessing a center's ability to implement those standards. It's talking about resource sharing. You guys can read the rest. But again, I think it's very important that as you guys go into each of your states, that you're talking about the importance of the comprehensive cancer control program, but also the importance of psychosocial. I threw up the Goal Bank. I don't know if any of you know about it. You guys can find the link in here as well. It's an interesting collection that George Washington University, I believe, has put together as well. Some of the information is not exactly updated. Some is very updated, but I would encourage you guys to go on out and look at that if you're interested in learning more as well. So again, you guys know the importance of getting this stuff into your states. You've heard it from both the other speakers too, that you got to get in there and you got to start swinging and asking a lot of questions, which is, what are you doing? Because there's a lot of evidence, there's a lot of data out there, and there really is no excuse as to why these states should not be adopting this language and doing something about it as well. So anyway, that's the short and sweet version. Hopefully that was fast enough for everybody as well. And I think at this point, I will just pause and I guess turn it over to Q&A at this point.
Thank you so much, Peter. Yes, I think we are going to move on to the Q&A section now, and I think we're going to turn it over to Vicki and Ruth to navigate that. But thank you, Peter, and thank you to all of our speakers tonight.
So Ruth, did you have a favorite question from the chat that you wanted to ask?
So let me go. I'm just trying to pull that up. So the last question here, do you think that the state coalitions can have an impact on area hospitals, the COG hospitals? And I'm going to direct that one to Eric Durbin.
Okay, so yeah, I mean, the impact on area hospitals. Yeah, sure, absolutely. I think, you know, engaging those facilities in the creation with the state coalition and the Cancer Action Plan. You know, those hospitals are key players, right, in implementing, you know, interventions. And so as we think about increasing services, you know, for children, I think those facilities, you know, would play a critical role in that. And so I think it would be important to engage with those providers and make them part of the process. So absolutely.
Thank you.
Angie, did that get at your question, or did you have a follow-up? Were you aiming in a different direction, or is that what you were looking for?
That wasn't what I was looking. That was partially what I was looking for, and I was typing quickly to try to clarify. I was thinking about the psychosocial issues, particularly that Peter raised, and you know, we've seen this. We know it's an issue. We know it needs to change, but hospitals talk about you know, the cost of hiring social workers, et cetera. And I haven't seen any change since we started talking about this, you know, what, 5-10 years now, you know. So I'm concerned, honestly, about how that, you know, what will happen. And I'll just leave it at that. But that's just my thought.
Peter, do you have a follow-up to Angie's concerns?
So, you know, Angie, it's good to hear from you, by the way. It is. And part of the challenge is the reimbursement pathway. And while what we're finding, because we're surveying a whole bunch of different hospitals, is that they're all over the map in terms of how they actually satisfy the stuff. Some hospitals have some really great models from a reimbursement perspective to try to deliver resources to do this stuff. Others have no idea. And so what I'm seeing is that it's almost like a case-by-case basis. So what we're trying to abstract from that is to say, here are some good models for delivery of how, quote unquote, how you do it, so that you can actually deliver on both the medical, but also the psychosocial piece as well. But it continues to be an uphill battle sometimes.
Definitely. Thank you.
So Suzanne Gwynn from Washington State, Ladybug House, had a question for Christy and Joan. Do you have a template that you're using to obtain information? Anything that you might share? She's trying to collect palliative and hospice numbers, length of hospitalizations for pediatric AYA over treatment, length of stay, disparities, SIBS, whatever, and thought that finding this data is pretty difficult. So she also was curious, and I think this is probably for all the speakers, what buy-in looks like. So Joan and Christy, go ahead and take the first one if you can, and we'll see where else that goes.
I want to use some of the things I saw Eric present on to create some new graphics for us. But we do have a cancer registry where we can put in data requests and get this type of information. I'll let Joan speak to if we have specific templates.
I think with the new version of the plan, the templates, we can certainly provide information, yes, but I think that really using the resources that we have at the Colorado State Health Department is where that drives a lot of what the information that we're able to pull out. So I don't know that I'm exactly answering your question as far as templates are concerned, but I think most of the plans really are looking at incident rates and along those lines. And I think we can probably pull from not only Eric's presentation, but some of the data sets that are included in our historic plans and provide some general summaries of the kinds of trends that we look at. So I think that's a feasible thing. As far as buy-in, I mean, I think that looks a little bit different for everyone. I think from where we sit as on the Colorado Kids Cancer Association side, for us buy-in really is how do we get institutional leadership and legislative partners to help us ensure that we have what we need to be able to get this done, that what we put in front of them can be executed on. So buy-in for us, we serve on a lot of the philanthropic boards that support our institutions, and so we look at how can we have conversations about the revenue that we generate through all of our constituents and all of our donors and families, and how do we put that forward in a way that helps us fund the programs that we would like to see happen. So not only partnering with the institution about helping drive it forward, but also making sure that if we're asking for the services, that we're in a position to be able to help the institution continue to support them as they go forward.
I'll add a little bit to that and just reiterate, I think really getting those physician champions at the table to help speak to the C level and get the buy-in from there. We found my task forces that are most effective have physician champions that are just spreading the word about it and getting buy-in. And then second, I think it's at a system and job level for all the organizations that you work in. So writing in 2 job descriptions of people that you hire, that they will work with the coalitions or work on advocacy type things. So just start institutionalizing it as you're hiring people, and get your other organizations you work with to also write it into job descriptions, so that people aren't having to do this on their off time or as extra or as volunteer time. Build it into the work.
There was a question here from Suzanne Gwynn at the very beginning asking what are the 29 states that do not have comprehensive cancer control plans with childhood cancer mentioned in it. That I can give you a few of them: Alabama, Arizona, Arkansas, Delaware, Georgia, Hawaii, Illinois, Indiana, Louisiana, Maine. It goes on and on. But you can find the list and the map on ACCO's website under advocacy and then state, and it's clickable map. So you can look there and you can find your states and see which ones have childhood cancer plans and which do not. And some that even, are classified as having plans or mentioning childhood cancer, it can be pretty minimal. So like Alaska is considered as having childhood cancer language in their plan, but it's actually just one line. Connecticut has 2 lines, Iowa has 2 sentences. So, even, the 21 states that do have childhood cancer language, it's often, not with goals and objectives and deliverables that need to be in the plans. So, again, there's a lot of work to be done.
So Lori Earle made a statement that I'm going to turn into a question about regional comparisons within states. I think that Dr. Durbin really pointed to Kentucky, and I think county to county. I think I understand that there's county level data for a lot of things that you were looking at. Is there another way to approach understanding those disparities, like with cancer clusters within a state, or in some other way? And I'll address that to Dr. Durbin, but anybody else might want to respond as well.
Sure. No, it's definitely challenging to explore, quote unquote clusters. And so I think if you recall the map that I showed of Kentucky, I cited a cluster where that cluster was really across, a large number of counties and really covered a very large population. So, looking for, clusters is a challenging, science within itself. And we do engage from time to time in pursuing some of those. I will say it's often extraordinarily difficult to find associations. I cited the fact that these smaller numbers and, epidemiologists and biostatisticians, we really, do have to rely on the numbers to indicate, some differences that we can really measure and quantify that move above and beyond, what might happen by chance. So those can be challenging. But I think at least in Kentucky, it's like, aggregating our county. We do have county level data, and we do map that. And when I pull up a map of incidence rates, and a large number of counties, are demonstrating those very unstable rates, which really makes comparisons at that level, pretty difficult. But we found it effective to aggregate the counties together in these area development districts and then one can take a deeper dive. Once you've identified a problem, that gives you, some evidence that maybe you can take a deeper dive and look within a region. And there are methods for conducting analyses, and that's actually at the population level. And that's what actually generated the map of clusters that I shared of the brain tumors in Kentucky.
Ruth, your turn.
I'm just
Christy, you
reading
want to
these
jump in on that
instead.
one?
I was going to show an example of a data visualization that Colorado has. Other people can see if their states have something similar. Is that okay? So this is our Colorado Health Information Data Set, and I have it right now just on total cases from 2018, but you can actually click over here on age groups, and you can see it breaks it down then by county, like how many actual cases there were in the county. So Arapahoe seems to have something going on. But everybody could, check with their state health departments and or their universities, whoever has the cancer registry, to see if they have a data visualization similar to this.
So one other question here from Angie is, will the state coalitions also seek to create greater awareness to the general community to encourage parents and caregivers to seek medical help before the cancer becomes untreatable? This is a huge issue for the AYAs. Would any of our speakers like to address that question? Maybe Joan?
Yes, absolutely. I think that one of the things that we have seen in Colorado, especially over the course of the last 15 years, even with the lapse that we had when we were in transition and had some of the leadership changes, is that we definitely have seen a significant uptick in grassroots advocacy efforts, bringing different issues forward. And I did see a note that popped up in the chat while we were talking, that PEDS and AYA are totally separate, and that it is a conversation that we're very that we know, we're aware of that. I think one of the things in the early iteration, it was as much as we could do to get that entire collective carved out in the state cancer plan. But over the last 10 years, we've seen a big push toward really ensuring that the adolescent young adult population has its own voice. And so we definitely are attentive to that. And I think that grassroots advocates and that the individual family organizations, especially when they pull together, are really able to help push those kind of initiatives forward. So we've seen a lot of success in that here in Colorado. I will say, and I don't know how this, and Vicki and Ruth, you may know, we talked a little bit on an earlier call. Colorado has one primary institution here that serves a 9-state region. We do have a second pediatric cancer hospital that's very strong in clinical care. But when you're dealing with states that have multiple pediatric centers of excellence, I think that's where your patient advocate population really has to take a look at. If you want to push certain initiatives through, really getting the leadership buy-in from all of the institutions. And I would kind of push back to you guys a little bit, since you have so much more experience across a national landscape of what that looks like from states that have more complex relationships among their institutions.
Ruth, there you go. You answer that one.
Well, I was going to say,
Sorry, Ruth.
I was going to say that, I think the state cancer plans need to identify what they want to target. And if it's going to be early diagnosis and, the AYA population, then that would be up to the committee and that's working on, their priorities. Awareness, I think, is something that can probably be done in the general community, in the childhood cancer community, as a separate entity. Obviously, it's really important with brain tumors to be diagnosed early. Melanomas, I'm not as convinced about leukemias. I think that outcome is not as critical for early diagnosis for that. But I think that can be a general national initiative and not necessarily something that has to happen within state cancer plans, I guess.
Right. Well, I would just add to Joan's point, I think it really is one of those instances that in states like Texas, where you have so many COG hospitals, but there are key ones that are, kind of plugged into the state mechanisms, having in these different, maybe they're in different communities, different cities, having your advocates singing from the same song sheets when they are going to the one in the couple in Houston, the one in Dallas and Fort Worth, and the one in Austin, so that as the decisions get moved forward, you have more coordination. I think we have time for one more question, even though we're a minute over, because Ann Raymer brought this up, and I think it's an important one. The SEER data is very, very available for incidence and mortality, but is there any guidance about collecting other kinds of data, morbidity data, survivorship issue data outside of state pediatric cancer registries? Dr. Durbin or Joan or Christy, do you have any kind of lead on those kind of issues? Because I think they're very important. And since we're trying to get evidence.
Sure. Just briefly, this is Eric. Yeah, it's actually a really good question. I think maybe part of the question is, even assessing, the number of survivors, maybe, in a population. And while it's not perfect, this question actually came up to our registry literally just this past week. And our registry and other SEER registries and other state registries, we follow patients for survival information. So we have, pretty good data on patients who are still surviving. And so we can probably at least estimate, the number of childhood cancer survivors and AYA patients, who are still living in our population. It's not perfect because we're not going to know, the patients who moved out of the state, or maybe patients who moved into Kentucky, who had previously been diagnosed with cancer. But it may be, an approximation. But that's just addressing, the numbers of survivors. So it's maybe not the other data sources that folks may be interested in.
Yeah, I really do think that this is an issue that we need to kind of work on as a community, and that is, given that we have, over 500,000 survivors, and some of them carry such a heavy burden in terms of their health. If there was a way to encourage tracking that, I think the costs associated with those kind of issues would be very powerful as part of our ideas. Anyway, we have overstayed our time today, and I thank everybody for attending. I thank Ruth for her partnership in hosting this meeting, and especially to our esteemed speakers who are amazing in the meatiness and optimism of the work we can do together. Ruth, I'll save the closing words for you.
Thank you. Yeah, thank you everyone for taking your time and for having an interest in, how we can impact on the state level. As I mentioned before, there's a lot of work to be done, and we really need to continue to ask ourselves, what about the kids? We can't forget the children. So if they're not in the state cancer plans, they're blip in the state plan and the cancer initiative going forward. So we really need to make sure that they're front and center. So thank you for your interest in this, and looking forward to, I guess, seeing 50 states with childhood cancer language in them. Thank you.